An abnormal heartbeat or arrhythmia often goes unnoticed until too late.
As a medical doctor, I know this only too well.
Don't let your heart take you out of the game.
Because when your heart stops, so do you.
Know your pulse. It could save your life.
It only takes 30 seconds to check your pulse. Visit knowyourpulse.co.za and stay in the game.
So the heartbeat goes on and on and on, but how aware of our hearts are we? Do you ever check your heart rhythm or pulse? Do you know what your normal pulse rate is? Well, the 3rd to the 9th of June is World Heart Rhythm Week. Now, Heart Rhythm Week is aimed at raising awareness and promoting better understanding of heart rhythm disorders or arrhythmias. So today we focus on knowing your pulse to know your rhythm, and together we can bring about change to ensure we all live healthier and longer lives. As we discuss arrhythmias, we'll be joined in studio by a cardiologist who's also part of the South African Heart Foundation, and we also have Director of Arrhythmia Alliance South Africa. We invite you to be part of the show by asking the panel some questions or simply just sharing your views with us. The number to call in that case is Johannesburg 714-5861 or 5877. You can also tweet us at SABC Health Talk or simply interact with us on our Facebook page, SABC Health Talk. So sit back, relax, and learn from this bumper show coming to you just after a short break. I'm Dr. Seloma Taung, and this is Health Talk.
Our Detect, Protect, Correct campaign. Detect AF through a simple pulse check. Anybody of any age can learn to take their pulse, and we have huge campaigns and materials available to teach the public and also to campaign for clinicians to regularly take the pulse when they're seeing patients with or without AF. It just should be a routine thing when you go to see your general physician. Protect against AF-related stroke with access to appropriate anticoagulation therapy, not aspirin. All the guidelines now have shown that aspirin is not recommended to reduce the risk of AF-related stroke. So we need to ensure patients have appropriate access and the most suitable anticoagulant for them. And then to correct the irregular heart rhythm. Anticoagulation therapy does not treat the AF. It's vitally important that you adhere to your anticoagulation medication, but if you have symptoms for AF, those will not go away with anticoagulation. You need to be seeing a heart rhythm specialist, an electrophysiologist, to find out what treatment options are best for you so that the irregular heart rhythm, AF, can be treated. We're engaging with all stakeholders for our Detect, Protect and Correct campaign. It's important to work with the general physicians because they are the first clinicians that patients go to, with the cardiologists, with the stroke experts and with the electrophysiologist, the heart rhythm specialist, and importantly with the pharmacist as well. Often patients go along obviously to the pharmacist to get their prescription exchanged, and that is where the pharmacist can come in and begin to open a dialogue. Also, we need to work with the public, make people pulse aware, know your pulse, know the difference between your heartbeat and your heart rhythm. Knowing your blood pressure does not detect an irregular heart rhythm. It's important to know your blood pressure, but it's also important to know your heart rhythm, and that's so simple with a Know Your Pulse.
Okay, knowing your pulse, knowing your heart rhythm is exactly what we're going to be talking about today. And it's a great pleasure to welcome our guest to take us through this. First up, Dr. Musa Mayayise, who is a specialist cardiologist based out in Butsilu Hospital out in Soshanguve. Welcome to Health Talk once again.
No, thank you, sir.
All right. And of course, next to Dr. Mayayise, we have Glenda Nichols. Now, Glenda is Director of Arrhythmia Alliance South Africa. Welcome to Health Talk, Glenda.
Thank you very much.
Perhaps let's start with you. I mean, we've put Arrhythmia Alliance on the spotlight there for now. Just tell us a little bit about what Arrhythmia Alliance is.
Okay, Arrhythmia Alliance is, we are a patient advocacy group. Our aim is to educate the population
Right.
about arrhythmia awareness and create awareness
Okay.
on arrhythmias. You saw Trudy LeBon now on the clip there. She was the founder of Arrhythmia Alliance in the UK.
Right.
And
When was it founded?
I think about 2004.
Right.
And we now have a global footprint. We now have 24 countries globally that actually have a representative of Arrhythmia Alliance. And our job is to go into the community, teach people about arrhythmias, let them know that arrhythmias exist, and show them what to do with it, what to look for, what symptoms to look out for, when to go to a doctor, and just guide them along their path.
Right.
Once they have a diagnosis of an arrhythmia, we are also there to support them,
Okay.
them and their families in life with an arrhythmia.
So do you have like branches in South Africa, and how many?
No, it's just me at the
Okay.
moment.
Right.
But we do what we can, and we go into the communities and we do screening.
Right.
And we're there on the other side of an email or a phone call for any assistance that they may need.
Okay.
With the whole idea is to prevent adverse events like strokes and sudden cardiac death.
Right. Dr. Maisa, before we start talking about arrhythmias,
Yes.
let's understand what the normal heartbeat is, how the heart normally functions, and how people can get to know their pulse and what is normal, and how, they can detect that something is not okay.
Okay. No. Thank you. The heart is basically a pump, and then for it to pump, it needs energy. Right. And this energy comes from electricity, and that is the component that we're going to spend most of our time talking about today.
Right.
So now the heart is like a 4-room house with 2 rooms at the top, 2 at the bottom, and then the upper rooms are thin walls. They receive blood from the body and the lungs. The bottom ones, they've got thick walls. They are the pump. So now there is electricity that comes to the heart. The electricity is well organized. It starts with the generator, which is in the upper room, which is called the SA node, and then it goes into in between the 2 rooms, which there's a timer there, which is called the AV node, and then in the bottom chambers, there's what is called the Purkinje fiber, which is a fast electricity conducting fibers, which results in the ultimate bed. So that is how it's organized. So what happens is this electricity comes in a pulse manner, which means there's one pulse after another, after another, after another, after another. So once that is organized and following a normal pattern, we'll call that rhythm. So because it's coming from the sinus node, which is the normal generator, it's called sinus rhythm. Now, we talk about the pulse. So the pulse is the ultimate, we normally check it here on the wrist. So that is the ultimate action. After the heart is pumped, then this blood goes and then we can feel the pulse.
Right.
Normally, the pulse is the range between 60 and 100 beats per minute. That is resting pulse. And then it can go up based on what you're doing. If you are running, then the pulse is going to go up because you need more blood. If something scares you, it's going to go up because you need more blood.
Right.
If you got pain, the pulse is going to go up. If you are bleeding, pulse is going to go up. You got infection, pulse is going to go up.
Right.
Drink coffee, pulse might go up. And then it can also go low. If you are like a fit athlete, the pulse can be slightly lower than an average person. If you have too cold, the pulse can go. If you got very high acid, it can eventually drop the pulse. Low oxygen can drop the pulse.
So when is the best time to check your pulse then?
You must check your pulse basically when you are much more relaxed, then you can check the pulse. They recommend that you measure it per minute. So if you can check how many beats in a minute you have, then you will know what is your resting pulse. So you want it to be between 60 and 100. So that is what is called the normal pulse. Yes.
So where do they normally feel? Glenda, perhaps you can come in here. I mean, this is what you teach basically. How do you teach people to measure their pulse? What should they do?
The easiest thing to do is on the wrist.
Right.
Take your 2 fingers, never your thumb, these 2 fingers, place them over the wrist in that position over there. Don't press too hard, otherwise you're going to block the artery there.
Yeah.
And then you'll actually just feel a little thumping against your fingers.
Yeah.
And then what you do is you set your timer or your watch or your alarm clock or what have you for 30 seconds. And then you just count the amount of beats that you can feel. Count that for 30 seconds and then times by 2.
Yeah. Okay, great. So that's the pulse.
Yes.
Then there's the concept of the rhythm.
Yes.
What's the difference?
So the rhythm is basically when we're tracking the electricity flow in the heart. So normally the electricity, like we mentioned, generator, timer, and then his packaging fiber. That normally is documented in the paper that is called the ECG, which records this electrical pattern for 30 seconds. And then at the bottom of most of the ECGs, there will be one which runs throughout the paper, which is called the rhythm strip. Then in that, we can be able to start checking these relationships. We start checking the gaps between the different beats, and then we can be able to work out what the rhythm is.
So talk about then that what can go wrong in the rhythm, and I guess that's the subject of today's show.
Yes.
You know?
So what can go wrong in a rhythm? So basically, we want a pulse to be between 60 and 100, which is the normal pulse. So if the pulse goes too low, on the below 60, so you can have diseases that affect different components of the heart. You can have the sinus node being affected, and then at worst, it can actually just don't give a beat. So which is what results in that flat line that we normally see, and then that is what is called arrest. Yeah. And then you can have the timer being also affected, and then at worst, again, the timer doesn't allow anything that is coming from the generator to go down. So that is the concept that we call complete heart block. So these ones are normally treated with a device that is called the pacemaker. We're going to go into later.
All right.
And then they can go fast, and then the fast heartbeat, they come either from the upper rooms or the lower rooms. The ones from the upper rooms, you can have a situation where another generator comes and compete with a normal generator, and it doesn't respond to the normal things that regulate the generator, and then cause you to go too fast. You can have the situation where there's short-circuiting of electricity. Some short circuits include involving the timer, and then there are certain maneuvers that you do to confirm that. And then others, they short-circuit with extra conducting a tissue, which is called the accessory pathway. Yeah. And then you can have the situation, which is what they were talking about in the opening clip.
All right. So I mean, I guess for the general public,
yes,
you know, they might not grasp all of these concepts.
Yes.
So what we essentially are saying to people is know your pulse, know what your rhythm is.
Yes.
And that we're saying it can either be, so if you know you're normal, you'd know that now it's much slower than it normally is, or much faster than it normally is, 100%. Or it's irregular. Yes. It's not beating in a regular fashion, correct?
Yes. 100% correct.
So how much do we know about arrhythmias, and how common are they?
Arrhythmias are a lot more common than you'd think.
Yeah.
They affect everybody, all ages. It doesn't care if you are old, young, rich, poor. It can affect absolutely everybody.
Yeah.
And it affects different people in different ways. The thing with an arrhythmia is there are some people out there that they don't feel anything. They have absolutely zero symptoms with it. They feel 100% normal, and yet they have an arrhythmia, but they are not aware of it. Then you get other people that have a slight arrhythmia, and they feel terrible with it. So the symptoms are very broad, and they can affect different people in different ways. So it's very important to understand that an arrhythmia can affect absolutely anybody at any time.
Yeah.
It can be very mild, what is actually affected, it can be very mild, or it could be very severe. In some cases, the very first symptom of an arrhythmia is sudden cardiac arrest.
Yeah.
So it's very, very important for people to be aware of the fact that arrhythmias exist.
Can it affect the young people as well?
100%. So you can have a young person who has never experienced anything, and then the first time to manifest is when they have an arrhythmia. So like what she's already mentioned here, it's what is called sudden cardiac arrest. So somebody just suddenly die. So it can happen that maybe you are driving in the middle of an open road with nothing, then you get an accident because of the arrest. You can be swimming, you're a good swimmer, there's no reason for you to drown, then suddenly you drown. The sad story I heard is of somebody who was coming from work, they take out the key, they're trying to open the door at the house, they drop down and die. Somebody goes to sleep, they don't wake up. So that is a sudden cardiac arrest. And then there are other manifestations that you can get, like you got this heightened sense of heartbeat, like very, very strong heartbeat or very, very irregular. That is what you call palpitation. And then you can also just have vague feelings, like especially with a slow heart rhythm, you are tired, you can't walk, you feel a bit dizzy, and those things. So those can be some of the manifestations of this condition of an arrhythmia.
However, palpitations, I mean, we feel when our emotions, get affected one way or another.
Yeah.
It does not necessarily mean that we have arrhythmias.
100%.
Is that correct?
100%.
All right. Okay.
Yeah.
You wanted to add something?
Yeah, you'll also find that some people with palpitations, they actually can't function with them. They feel absolutely terrible to the point that it actually starts interfering with their quality of life.
Right.
And that's when it becomes a problem, and that's usually when they seek medical assistance.
Right. I guess the big question to then ask is, who gets arrhythmias and what are the causes and risk factors? You know what? We're going to do that after the break. Okay. Time for a quick break. When we come back, we come and discuss causes and risk factors. Please stay with us.
We do not just speak. We let every voice in our nation find full expression in language and in culture. We do not just teach. We empower all people with education. We do not just bring you the news. We place you where the news is happening. We do not just entertain. We take you on journeys. We do not just broadcast sport. We create an arena for sporting heroes to inspire you. Ours is not just a job, it's a calling to ensure that everyone in our nation is informed, educated, and entertained. We're able to do this because you do your part. SABC TV licenses. It's all made possible by you.
The SABC News mobile app is your one-stop digital portal to all the news you need. Stay connected with the latest in breaking news. Watch the SABC News channel along with clips and live streams of all the big news events. And listen to all the SABC News radio stations live, including podcasts and much more. Simply download the SABC News app to your Android or iOS device from either the Play Store or the App Store. SABC News, independent, impartial. Every high-profile court case, every breaking news story.
The manner in which these audits are done. Why is it targeted to blacks and Indians?
Every inquiry. We are there, front and center. We also bring you an hour-long breakdown of the day's markets, simplifying the numbers for your better understanding.
When everyone is too excited about the market, that's normally when things start turning.
All this and more. This is On Point.
Welcome back. We're talking arrhythmias with our guest, Dr. Musa Mayise, a specialist cardiologist out in Butsilo Hospital in Pretoria, and of course Glenda Nichols, Director of Arrhythmia Alliance South Africa. Just before we start talking about causes and risk factors, we obviously briefly described the different types.
Yeah.
But clearly there's others that are a bit more common than the others.
Yes.
I mean, we heard in the clip there was reference to AF.
Yes.
Please just tell us briefly what that is.
So atrial fibrillation is a situation where in the upper rooms of the heart, there is this chaotic situation where many generators develops and then they take over. So the risk for it is normally the heart that is structurally abnormal. It can happen in what is called the structural normal heart. Yeah. And then normally that is, we look for things like thyroid that can exacerbate that kind of situation. And then at worst, it can actually cause a clot that to form in the heart, and the clot can break, goes to the brain, and causes a stroke. Yeah. So part of management of it is we've got the electrical problem of the heart, but we also got the clotting issue that we need to also address.
That we'll talk about when we talk to the treatment.
Yes.
But I mean, I mentioned AF. Is that the only or the commonly known one?
Atrial fibrillation at the moment is becoming a bit of an epidemic. It's considered a global epidemic.
Right.
We're seeing more and more of it, and where it used to be sort of affecting people 50 years and upwards, we're now seeing it in younger and younger and younger people. Right. We had one the other day that was in their 30s. So it is starting to affect a lot more people and a lot quicker.
Right.
So another one that we tend to see a lot more commonly, it's what is called the AV nodal reentrant tachycardia. So it's a big word. So it's coming from the upper room of the heart, and then as it reaches the timer, then it starts forming a short circuit. Instead of the signal going down, it forms a short circuit and go very fast there. So part of dealing with it is interrupting, you delay the timer. So you can actually break it that way, then you know that is the rhythm. So normally it goes very fast, above 180 beats per minute.
Okay.
And then
so who's at risk of developing arrhythmias? Are there genetic factors perhaps?
Yeah. Yes, there are genetic factors. So those patients are normally identified if they are younger than 40, then they manifest for the first time with a arrhythmia, especially of the lower room of the heart, which is called ventricular tachycardia. If they're manifesting for the first time with that, or they survive a cardiac arrest, then you normally, with those people, you will go to the family and start checking whether there is a risk for arrhythmias. So they normally check ECGs in the family members, and then if there's higher suspicions, there's also some genetic specialists who can do bloods and check the genes that are involved in those kind of patients.
So what you're saying is, for somebody watching the show, if I now know that my parent has been diagnosed with some form of arrhythmia,
yeah,
I have a strong chance of having arrhythmia myself. Is that what you're saying?
Yeah, especially if they're diagnosed early, like they normally say younger than 40. And then there are also a lot more arrhythmias that we see in practice, which are in the structurally abnormal heart. If the heart is a weak pump, it's too thick, or it has other diseases, then that also puts somebody at risk for arrhythmia. But when they come later on, they tend to have that secondary cause rather than the genetic ones. So the genetic ones, normally they are in the much younger populations. That's what we tend to see. And that's why we tend to look more at the family, to screen the family for this kind of familial pattern of the diseases.
And if I may just add as well, if within a family you have quite a few unexplained deaths, that's also cause for concern. So then you would need to go to your doctor, or it would be advisable to go to your doctor and get tested for any genetic condition that could have caused those unnatural deaths. And when I say unnatural deaths, I'm not just saying die in your sleep or what have you. A car accident when they're the only person on the road, where there's no other car involved, a drowning, falling off a cliff. Unexplained deaths of that nature also could constitute a genetic component for a cardiac disease, which is also important to be looked at. And in this country, there is one centre that actually does do genetic testing, which they send down to Cape Town. So it can be done, can be tested here. There's a bit of a waiting period for the result, but it is certainly worth doing.
Okay. So are there other external causes for arrhythmias?
Yeah, just on genetics, there's also one condition which normally can lead, especially famous soccer players who just drop down and die. So this is the condition where the heart muscle becomes thicker than normal, and then that can result in the scar forming in the heart and then developing abnormal electricity that can lead to the heart stopping. So that is what is called hypertrophic cardiomyopathy. It can have the familial pattern as well. And then there are other causes, like your normal conditions that we normally deal with, your high blood pressure that is there for a long time, it causes changes in the structure of the heart, your diabetes. If the patient is of older age, if you're above 65, you're at risk for structural problems of the heart. If you're a smoker, you're at risk. And then there's also one particular condition, it's called the holiday heart syndrome. If you go binging on alcohol very hard, then it can disrupt the electricity of the heart as well. So those are some of the additional causes that can lead to the structure of the heart being involved, and then it leads to arrhythmias. And then the one which we also deal with quite commonly, it's in the presence of a acute heart attack. If a heart attack is happening now, there is a fresh wound in that heart. That can come with an arrhythmia as well associated with it. Even after the time of treating the acute, and then there's now a scar in the heart, the scar also can cause the arrhythmia to happen inside the heart.
Okay. You mentioned alcohol and, but what about other drugs?
Well, that's what I was going to mention as well, is a lot of the medications that you take for other conditions, or even just over the counter, are pro-arrhythmic, what we call pro-arrhythmic, and they actually tachycardias, fast heart rhythms, which could be very dangerous as well.
Can we name just a few of those, just a few examples, just so people can know?
Are we allowed to?
No,
well, we don't need to.
No, I think
name.
it's fine. Like there is a condition that is called long QT. So it's part of when the heart is starting to recover from the electricity. So the QT can become long. So there are drugs that actually prolongs that. So some of the antibiotics that we use, especially the antibiotic group that is called the macrolides, it can cause that long QT. Some of the anti-arrhythmic agents that we use, that's why we have to screen the patient properly. Some of the agents that treat the arrhythmia, they can prolong the long QT. Like over-the-counter stuff that is mentioned, the flu medications, your sinuses medication, and this kind of over-the-counter stuff, they can cause that long QT, and then when you got the running nose, part of the components that are there, some of them, they can cause the heart to go a little bit faster.
So in essence, what are we saying then about, people taking over-the-counter medication if they are at higher risk or if they've been diagnosed with any of these conditions?
They should read the package inserts carefully
Right.
on all the medications. Look at the warnings, look at the contraindications.
Right.
Be very careful of mixing medications, because often by mixing medications, they actually have an effect on one another. And that could actually cause a bit of a problem as well. And most of your psychotropic medications actually cause tachycardias as well. So be very, very careful with those.
Okay. The one thing we spoke briefly about during one of our breaks is the issue of athletes, high-level athletes.
Yes.
And, after a period of time. Your comment on that?
Yeah, so now with athletes, what tends to happen is the more you exercise the heart, the stronger the muscle is. So you need two things to have what is called cardiac output, to be able to take out enough blood to supply. You need a strong pump and you need a heart rate. So now with them, because the pump is now stronger, they don't need as many beats to be able to get as much blood out, because the pump is stronger. So the heart rate tends to be slightly on the lower side. And then the other thing is, you've got two systems that regulate the heart rates and the blood pressure. It's called the sympathetic and the parasympathetic. So the sympathetic is the stimulating one, parasympathetic is the relaxing one. So now with them, the parasympathetic tends to be much more stronger over time, then which also further slower down the generator of the heart. It slows down the timer of the heart, and then they can come and look as if they've got some conduction problems while
And just to be clear, we're talking about high level.
Yes.
Endurance type athletes like, ultra marathon runners. and so on.
I was going to mention Mutibi, who won the Comrades.
Yes.
Like if he's going to come to me, I expect his heart rate to be way down. I expect he might have some sort of heart block or whatever. But for him, it's normal because the heart is strong to be able to pump.
Okay.
100%.
But we're not necessarily saying that they have an abnormal heart.
No.
Okay.
No.
And also that we're not necessarily saying that partaking in normal, regular physical activity will result in some heart problem.
No, that's not what we're saying.
All right. I think that's the message I wanted us to make sure that we get it out clearly. Right, time for another quick break. When we come back, we continue our story on arrhythmias. Please stay with us.
Baletile Mthethwa joins us now live. MNS attorneys were mandated to conduct these reports and investigations. What sort of processes did they follow?
We heard Tiamo explaining that they worked with actuarial scientists in order to investigate these transactions.
Slap suits, tell us more about this.
The concept of slap suits, which is litigation often used by big companies to silence critics.
We as civil society won't stand for this kind of intimidation and harassment. If you come to South Africa, you need to obey the obligations that you have in terms of the laws of this country, including environmental laws.
Every high-profile court case, every breaking news story.
The manner in which these audits are done. Why is it targeted to blacks and Indians?
Every inquiry. We are there, front and center. We also bring you an hour-long breakdown of the day's markets, simplifying the numbers for your better understanding.
When everyone is too excited about the market, that's normally when things start turning.
All this and more. This is On Point.
Welcome back. If you've just joined us, we're talking arrhythmias with Dr. Musa Mayise, a cardiologist from Butilo Hospital in Pretoria, and Glenda Nichols, Director of Arrhythmia Alliance South Africa. Now, before we carry on, we have Thelma on the line from Port Elizabeth. Thelma, welcome.
Yes, okay.
Hello,
Thank
Thelma.
you.
Yes.
Hello, doctor.
How are you?
Fine, doctor. Unjani wena, doc?
Sikhona. Your question, ke ma'am?
I-question yami nje mamele ngonitshela yapha eTV doc ne.
Yeah.
Lo sisa wami osoneke last year ngoMay. In fact, uye wayefit teacher on that person.
When done?
Wayefit teacher.
Oh, okay. All right.
Wavela wanefit
Yes.
So samtharake samsesibhedlele and then edorangisa kwachaza into ba hayi makalale ngoba sibone enye into ngoku nakwi x-ray yakhe into ba inhliziyo yakhe le inkulu and yet islantile.
Right.
Lesicima mama silali sithini.
Okay. All right.
Cha ke ulele only that testing esibhedlele wacela yena Friday into ba abuye Monday.
Okay.
So uye Monday ye wasweleka ke engekani.
I'm sorry about it. Let's hear what the experts have to say about it. Okay, all right. Okay, thank you, Thelma. So just briefly for the sake of those that couldn't follow, her sister was admitted to hospital after having convulsions at home, and upon admission they checked her out and realized that there was something wrong with her heart, that her heart was enlarged, and after a few days, unfortunately, she passed on, and she basically wants to know what could have been the problem.
Look, if the heart is enlarged, like then she said, risk of developing arrhythmias. So more especially the ones that are most dangerous that can lead to the heart pumping ineffectively or not pumping is the arrhythmias that comes from the bottom chamber of the heart. That is called the ventricular tachyarrhythmias. So they can be what we call tachycardias, or they can be fibrillation. So fibrillation is the situation where the heart is now starting to do this, or it can just be arrest. So it can be that she had one of those electrical problems of the heart. So what is needed is basically the basic investigations. The simple ones and the most common one is the ECG, that we track this electrical pattern, then we can be able to trace exactly what it is that is happening there.
Okay.
All right.
I guess this leads us into what we want to talk about now, the treatment. How do we treat these conditions at the time that they're diagnosed?
Yeah.
Obviously, in certain instances, like you mentioned, it might be an emergency. It's a heart attack. That's the first time, we get to know that there's a problem. But just the principles in general of treatment.
All right. So the principles, I would say the first one and the most important one for me, get the diagnosis.
Yeah.
Yeah, don't just call and then say, no, the pulse is 180. If you have not tracked the relationships of get the diagnosis, do an ECG, get a diagnosis, and then you can be able to move from there. Then the second most important thing is the beating of the heart.
Yeah.
Do you have a situation which has affected the beating so much that it's not beating very well? So we can see with what is called the hemodynamic collapse. So you look at the blood pressure if it's low, you look at the consciousness if it's low. Once you're in those situations, correcting that rhythm is very, very urgent. So that in those circumstances, that's where they normally going to give the electric shock. Okay. So we apply the pads on the chest, and then we give a shock, and then take the rhythm back from the abnormal to the sinus rhythm.
Okay, so I mean, obviously, this is what the doctors would do in a hospital.
Yes, yes.
Perhaps let's just take one step back and say to the normal public out there, what are those issues that should trigger them saying, I have to go and see a doctor?
Yes.
What do you normally teach?
If they get palpitations where they feel the heart pumping in the chest, that should be a trigger to go to the doctor. Unexplained dizziness, unexplained fainting, shortness of breath, extreme fatigue, just making your bed suddenly tires you where it didn't before, that kind of thing. Just a general feeling of being unwell. And I think that basically covers it, the main ones that they would then go to the doctor for, get treatment for.
Right.
And then to start off with, it would be sort of the non-invasive testings that would be done really, would be your ECG test, a Holter monitor, which is a 24-hour or a 3-day monitor of your ECG to see how often you're in and out of it as well.
Your blood pressure, obviously.
Yes.
All those basic stuff.
Yeah.
Okay, so there are things then that are done in that acute state.
Yes.
To try and normalize
Mhm.
and save a life, as it were.
Yes. So we've mentioned about restoration of the rhythm.
Right.
So that's what we're doing when we're shocking. Then we need to check what can be either cause or can be sustaining the arrhythmia. One of those causes is if somebody is giving a heart attack now, so you'll need to deal with that urgently. And then if you need to check on the bloods, if there is a drop in certain electrolytes, one, potassium if it's low, magnesium if it's low, calcium if it's low, that tend to sustain and then cause the recurrence of this rhythm problems. So you also need to deal with those issues. And then if the patient is hemodynamically stable, then you've got options like what we're mentioning, that if they've got a rhythm that depends on the AV node, you can just at the angle of the jaw, you can just massage in a circular motion there, you do what is called the carotid sinus massage. It tends to delay the AV conduction, and then it can break that AV nodal dependent tachycardia. And then the other thing they give in the emergency settings is a drug that's called adenosine, which also temporarily stops the heart, and then it sort of restores the normal rhythm.
Okay.
Yeah.
So essentially what you're saying is there are obviously those things that can be done in hospital and so on, and then there can be medication given.
Yes.
So is there a difference in terms of how you treat the slow rhythms versus the fast rhythms versus the irregular ones?
Yes. The slow rhythms, the first thing to check in patients is drugs. Like if you got hypertensive, they can be having a beta blocker that is slowing down the heart. Certain calcium channel blockers could be slowing down the heart. Then you check those kind of effects and then you deal with them. And then if you are only left with a rhythm problem, then the worst of them, they tend to get a pacemaker. So pacemaker is a device that we put just below the collarbone, and then we put the wires that goes into the heart, and then it starts playing this role of monitoring and then giving advice and keep the heart going, pumping. And then the faster ones, there are drugs that correct the rhythm, or they are called antiarrhythmic drugs. So we will normally stratify patients. Do they have the heart that is normal or the heart that is abnormal? If the heart is normal, then we've got more options. Drugs like flecainide, which are much more effective, easier to dose. And then if the heart is structural abnormal, then we'll have to give amiodarone, which is which has problems with the thyroids and whatever. But in a structural abnormal heart, it tends to be much more safer. And then in patients with heart attacks and those kind of problems, they get a beta blocker, which tends to prevent the recurrence of this arrhythmia. And then in the patients with atrial fibrillation, which is what we started with, it's a different ballgame because we've got an issue of rhythm, we've got an issue of clotting. So for the rhythm, there's two different decisions you have to make. Are you restoring the patient back to sinus rhythm, of which you can give the drugs and you can also shock the patient? Or the patient has behaved this chronic fibrillation on a chronic basis, then you can give the drugs that controls the rate of the arrhythmia.
I'll tell you what, let's just pause for a while and take Debbie on the line from Cape Town. Debbie, welcome.
Hello.
Hello, Debbie, are you there?
Yes, I'm here.
Okay, your question or comment, please?
I'm very healthy, but it was last year, November. I thought when I lay down, I can feel my rhythm is 1, 2, 3, 4, 5. But at the 6th one, it's a longer period before the 6th one. And then just after the 6th one, there's another beat. And I'm healthy, but the problem is I get very excited or afraid or scared, because I know the 5 beats is okay, but why is the 6th beat so a longer period before you came, and then immediately after the 6th beat there is another beat?
I see.
And I went to Tygerberg Hospital, and they for 3 times they gave me that image where they put on the heart and so forth, and when they put it on my ankle, they can see, they are also worried. They can see and they can hear the heartbeat is not right. For 3 times, and then they put it on my hip, and then it came right on the paper. So what is it? Is it see it's something I need to be worried about or what?
Okay. All right. Thank you so much for that very clearly described problem, Debbie. Let's hear the expert.
Okay, so what she's talking about is basically an irregular rhythm, and she doesn't have symptoms from what I can gather.
Yeah.
So now there are different causes for that. You know, like in the normal heart rhythm, there is what is called beat-to-beat variation. So as you're breathing in and out, and the heart rate changes slightly from beat to beat. And then that is called sinus arrhythmia. And then there is also the situation where you can develop what is called ectopic beats. So ectopic beats is the beat that arises early on. So they tend to disrupt the feeling of the heart, and then what the heart tends to do in compensation, it lengthens the period of feeling in the next beat. So which is what you could be talking about. That if an ectopic length, then there's a longer period, and then
so it appears that she was assessed.
Yes.
Should she be worried?
I wouldn't necessarily know what it is that they focus now. There's details of what you check in the heart, but one of those signs that there could be a problem with the rhythm, if you collapse. Then you know that rhythm is probably problematic. If they find something wrong in the electricity of the heart, she says she's done some electrical tests. If they found wrong with the structures of the heart, if you've done a heart sonar, you find that the structure there's something wrong, then you are. And the family history. If in your family somebody died under mysterious circumstances that were mentioned here time and again, then you maybe are sitting with a basket that you might run into certain issues.
But
otherwise,
but she did the right thing by obviously consulting,
100%.
and she's in right hands.
Yeah, that's what every patient should do.
All right, time for another quick break. When we come back, we'll wrap up our discussion on arrhythmias. Please stay with us.
We're explorers. We always have been. Endlessly curious. Always looking for answers. For new frontiers. For new stories. Because that is who we are. From script to screen. From yelling action to taking you on a journey. Radio producers. Script writers. On-air presenters. News reporters. Sports analysts. We spend late nights creating captivating storylines and earlier mornings keeping you informed, educated, and entertained. For us, it's not a job, it's a calling. We do this and more because you do your part. SABC TV licenses, made possible by you.
Welcome back. We're talking arrhythmias with our guest, Dr. Maisa, cardiologist from Pretoria, and Glenda Nichols, Director of Arrhythmia Alliance South Africa. We now have Maria on the line from Niger. Maria, welcome.
Welcome, doctors, and greeting to all that. In 2000, I've got an accident, so I've got an internal bleeding when my doctor punctured. On the left-hand side, so they just bandage me, then they say, and then now, I lost my son Monday of February, so due short illness. And then I feel increase or feel it, and then I've got a sharp pain in the heart.
Okay.
So I don't know, because whether we see about doctors diagnose and that I worry to
All right.
But I still refer to the back accident. It may be surface I can review.
Okay. I'm so sorry for your situation there, Maria, but thank you very much for your question. For the sake of everybody else that couldn't follow, Maria had an accident some time ago. It was in a taxi that overturned and so on. Got some chest injuries, but it appears that there wasn't much that was found. She was just given bandages at the hospital, sent away. And unfortunately, she lost her son recently, and she's got these symptoms that, her heart feels like it's stopping, I suppose related to the issue of the loss of the son. But what she wants to know is whether or not these symptoms are related to that accident that she had before.
No, I don't think they will be directly related. So probably what might be is that there is a lot of psychological stress that we predict there. It can manifest itself as a heart symptoms, or it can sort of put the heart at risk of developing the arrhythmias.
Yeah.
So I think if these things are continuing and then they're not getting better, probably she can get it checked out, like the clip they advise. You can start from a physician who can be able to check you, do ECG, and then do the basic test. And then if they are worried, they can refer you upwards.
All right.
Yeah.
Okay, let's talk about people that have been diagnosed with arrhythmias on some form of treatment or other. How do we support them? I mean, some of them have to take medication on a daily basis. Clina?
The important thing really is to stress to them the importance of compliance on that medication.
Yeah.
Often when people start feeling better, they stop taking the medication and then they get worse again. So it's important for them to realize that they mustn't self-dose, that any changes in the medication needs to be done through a doctor. They need to be the ones to make the change. And what I try and do is I try and put people I try and match apples and pears. So I try and match them, and I get people with a similar condition in touch with one another so that they can actually form a support group amongst themselves, so that they can chat and compare notes. Any side effects that you get from the medication, because of course all medications do have some side effects, then before they stop it or change it, they need to chat to their physician about it.
Okay. We spoke about the clotting side of atrial fibrillation.
Yeah.
So some of them would be on anticoagulants.
Yes.
Let's just get straight to the point. What should be their responsibility?
So their responsibility is, it will depend on which anticoagulant you take, because the one we commonly give is what is called warfarin. So warfarin interacts with a lot of drugs. It interacts with food, a lot of food content. So to try and make sure that blood is thin within a certain range, the patient has to go for check with what is called an INR with a lab. So it becomes a bit of an issue with costs, but it's important that the patient goes so that they can prevent themselves from getting a stroke. And then that will be one of the responsibilities. Then if they've got newer drugs, what is called direct oral anticoagulants, those drugs, they don't need much monitoring. So fortunately for the patient, they don't have the responsibility to go to the lab, but they still are responsible for taking their medications on a regular basis. And then it also becomes a bit more complicated when they need to go for procedures, like if they're going for a dental procedure and those kind of things. Then they need to declare that they are on medication that is coming from a cardiologist. Then normally the dentist is going to ask us to write a treatment for them.
Okay. Let's take our last caller for today, Mrs. Boysens from Bloemfontein. Hello, Mrs. Boysens.
Hello.
How are you?
Good, and you, doctor?
Good, thanks. Your quick question, please.
Doctor, I had 3 operations.
Yes.
3 heart attacks.
Right.
3 years ago.
Right.
I just had another one 2 months ago. And for all 3 heart attacks I got, they put stents in.
Yes.
Now, the first heart attack I got, I was fine. The second one, I was also fine. The third one now, I'm like a cabbage. I'm out of breath the whole time. I can't go to the one room, the other room. Then I'm exhausted, out of breath. And I don't know what they did. So I just want to know, is there a cure? What is it? I must do because I'm emotional all the time because of my health condition.
Yeah.
Because I used to be an active person, but now I can't even bath myself after the third op.
Okay, Mrs. Boysen.
Now 2 months ago.
Yeah. Thank you so much.
I can't walk.
All right. Okay.
I walk from here to the other room that I must sit. So, and I'm not that type of person.
Yeah. All right. Thank you so much for your question, and I'm so sorry about the situation, but let's hear what the doctor says very briefly.
Okay, so I think we can just read from a story. 3 heart attacks. So basically what happens with a heart attack, you block a blood vessel, certain part of the heart doesn't get the blood, and if the situation continues for long, that part dies. So what tends to happen over time, the heart gets to be a bit weak, which could be a situation as things stands. You know? So with a weak heart, then it becomes difficult to walk because the heart is not pumping very strong and stuff. So it can be that you're sitting with that kind of situation. The other scenario is it can be that there are many vessels that are blocked. And then that also can be the situation that she's sitting down with. What is important as far as this talk is concerned is since he's had a heart attack, the heart definitely has a scar, and then that scar puts it at risk for ventricular tachycardia. And then what you need to do is to take the medications and don't stop. Yes, so that's what I would advise.
All right. We haven't got time, but just in the last minute, people who are on treatment, there's often things that people can do that may trigger attacks of, arrhythmic attacks, so to say.
Stress and fear, anxiety, those are big triggers, but often you can't avoid those. Excess caffeine.
And non-compliance is also a big issue. Some patients have got arrhythmias that come more often, so that you need to give them medications that will stop that from happening.
Right.
So if they are not compliant with that treatment, then that can lead to problems with the arrhythmias coming back. So that is one of those problems that we get to see in practice. And then the others will be adding new drugs, like what you're explaining now. Some of the interactions of the drugs, they can work on the electricity of the heart, and they can actually induce arrhythmia. So once you are on those drugs, when you add, like what you said, advice that you gave, read the packet insert and make sure that these things doesn't have an effect on the heart.
Before I forget, somebody asked me the question to ask. Do pacemakers last a lifetime?
Oh, I wish they do, man. Whoever's going to discover that will make a lot of money. So pacemakers, basically, they run on a battery. Or maybe let's discuss what they are. The pacemaker...
Well, unfortunately, we're going to have to be just very brief.
Now, the pacemaker is a device that looks for gaps in the rhythm. So once there's a gap, then they fill it up with a beat and then make sure they keep the heart going. So because they are working all the time, if they are not firing, they are reading. So they're working all the time. So the best in the market at the moment, they can last up to 12 to 13 years. Then you have to come for replacement. If there's excessive use, they can even go shorter.
All right, okay. I'm afraid that's where we're going to have to leave it because of time. And I want to thank you so much, Dr. Mayais, a cardiologist from Victoria, Glenda Nichols,
You're welcome.
Director from Arrhythmia Alliance, South Africa. Thank you so much for your contribution. And thank you so much for you guys at home for staying with us. And we're back on your screens again next week, same time. And until then, please do take care.